Hai, Assalamualaikum warahmatullahi wabarakatuh. My name is Hayatun Syamila binti Muhammad Nasir. Today, our group will present nutritional management of spontaneous bacterial peritonitis and right pleural effusion with underlying chronic hepatitis C. So, for the patient's personal details, our patient name is Mr. T. He is 44 years old. He is a Malay man and he is also a single man and currently living with his mother. He also was an extravenous drug user such as heroin, ganja and pilkuda. However, it was reported that he is still taking pilkuda.
Now we move on to the medical diagnosis part with me, Nikmai Zato. Okay, so previously, Mr. T had been diagnosed with chronic hepatitis C, possible of having chronic liver disease and portal hypertension. So Mr. T had been diagnosed with chronic hepatitis C, which is actually an underlying disease. Okay, so this underlying disease can cause lots of other diseases such as pleural effusion, which will lead to hepatic hydrothorax. Not only that, chronic hepatitis C with portal hypertension can also cause spontaneous bacterial peritonitis. And besides, chronic hepatitis C can also cause hypochromic microcytic anemia, hypoalbuminemia, and also hepatic encephalopathy, which is also a sign for other diseases and also a disease caused by chronic hepatitis C. Okay, so now we move on to the explanation on how chronic hepatitis C can cause pleural effusion and spontaneous bacterial peritonitis. Okay, so basically, ascites occurred due to a combination of elevated level circulating pressure in the veins, or also known as portal hypertension, and also due to a reduction in liver function. As we all know, chronic hepatitis in Mr. T, which will increase intrahepatic vascular resistance to portal flow in liver cirrhosis, and this will increase portal pressure and thus will contribute to portal hypertension. Then these portal hypertensions will lead to water and sodium retention, which cause the overflow of fluid into the peritoneal cavity and thus ascites develop. Furthermore, the transitive fluid of ascites, which is predominantly has a low opsonic activity that provides a favorable bacterial growth environment, and this will lead to spontaneous bacterial peritonitis.
Hi, I am Runia Ashikin and now I will proceed with the medications or drugs that are taken by Mr. T. First of all, he is prescribed by syrup lactulose 15 ml 3 times daily for the treatment of hepatic encephalopathy to relieve constipation and also reducing the amount of ammonia in the blood of patients with liver disease. Next, he also takes 40 mg of pantoprazole once daily to reduce the risk of stomach ulcer formation. To explain, patients with spontaneous bacterial peritonitis have increased gastric acid formation to defend against the enteric bacteria. So, this increased gastric acid secretion will lead to peptic ulcer formation. So, pantoprazole will be used to decrease the amount of stomach acid formation. Next is 40 mg of furosemide and 50 mg of spironolactone, also taken by Mr. T once daily. The combination of furosemide and spironolactone is used for the treatment of ascites due to chronic liver disease and also to lower the high blood pressure. For your information, furosemide and spironolactone are type of diuretics. Next is double hematinics, which are ferrous fumarate and also folic acid. It is used for the treatment and prevention of low iron levels in the blood. Lastly, he also prescribed with rocephin intravenously 1 gram once daily to treat the bacterial infections which are in the spontaneous bacterial peritonitis.
Next, we move to the assessment part. For the anthropometric data, the weight is 63 kg. The height is 160 cm. The weight after removed ascites is 57 kg. The BMI is 23.3, which is considered normal. For the biochemical data, the hemoglobin value is 8.0 gram per liter, which is lower than normal. The red blood cell value is 3.1, which is lower than normal. albumin value is 30 gram per liter, which is lower than normal. The ALT value is 58 UI, which is higher than normal. The AST value is 68 UI, which is higher than normal. And the INR value is 1.21, which is also higher than normal. Next, the clinical data. The patient has high temperature, which is 38 degrees Celsius. He also has ascites grade 2 and abdominal distension. For the dietary data, the calories intake is 979.8 kcal. Total intake of carbohydrate, protein, and fat were 170.11 gram, 29.16 gram, and 19.47 gram respectively. It also shows low intake of protein.
From Mr. T's case, we found out two nutritional diagnoses. Okay, so for the first one, we have inadequate iron intake related to low animal-based protein consumption, as evidenced by low hemoglobin and red blood cell level. The second one is inadequate protein energy intake related to low nutrient-dense foods, as evidenced by diet history, which is 979.8 kcal, which is comprised of 69.4% of carbohydrate, 11.9% of protein, and 18.7% of fat intake daily.
For the dietary intervention, our goals are divided into two. Firstly, short-term goals. We want to increase the energy intake by 50%, and for the long-term goals, we want to achieve normal value of hemoglobin and red blood cells concentrations, and we also want to reduce the abdominal distensions. Alright, for the objective, we want to increase the appetite and optimize energy intake. How? We will provide small and frequent meals with energy requirement of 1,500 kcal and protein about 1.2 to 1.5 gram per kg of body weight per day. And for secondly, we want to reduce the fluid retention by limit his fluid intake by 1 to 1.5 liter per day and sodium intake less than 2 gram per day. And lastly, we want to improve the anemia condition by providing iron-rich food.
Next, we move to intervention. To calculate the estimated energy requirement, we use quick method and Harris-Benedict equation. For quick method, the estimated energy requirement is 2,280 kcal, while for Harris-Benedict equation, the estimated energy requirement is 4,058 kcal. Next, for the estimated protein requirement, we choose range from 1.2 to 1.5 grams per kilogram. The EPR for this patient is 68.4 grams to 85.5 grams. For macronutrient distribution, we allocate 20% for protein, 55% for carbohydrate, and 25% for fat. With 7 exchange for protein, 14 exchange for carbohydrate, and 4 exchange for fat respectively. So, this table shows the distribution of exchange portion according to the food group.
Next, this is menu suggestion for Mr. T. We created 2 menu plan for weekday and 1 menu plan for weekend. For menu plan, we suggested food and drink for each meal time starting from breakfast, morning tea, lunch, tea time, dinner, and supper. This is menu plan for day 1, which is weekday. This is menu plan for day 2, which is for weekday, and day 3 for weekend.
Monitoring and evaluation for Mr. T include monitor on weight changes to avoid gaining weight. Second, monitor on dietary and fluid intake to increase energy requirement by 50%. And lastly, monitoring on his biochemical data to achieve normal RBC value, which is 3.8 to 4.8, and also hemoglobin value, which is 14 to 18 gram per liter.
Next is discussion. Methamphetamine is one of the main components in the YABA drug. According to Jahan and Rahman, this component suppresses appetite and increases the release of dopamine in the brain, resulting in the feeling of pleasure, movement, and motivation. This finding shows why Mr. T had lower energy intake per day, which was 979.8 kcal per day, despite having a heavy job and being sick. Mr. T also had suffered from right pleural effusion and developed ascites. He had an underlying disease which is chronic hepatitis C, which explained the reason for having an accumulation of fluid in the pleural cavity, or also known as ascites. The first-line treatment for Mr. T is through a dietary approach by creating a negative sodium balance by restricting sodium intake and administering diuretics. He should be on a sodium-restricted diet with less than 2000 mg per day. Other than that, all the side effects from all the medications he takes affect Mr. T's dietary intake. Stomach pain or cramps, abdominal discomfort, and restlessness can lead to low appetite and reduced ability to eat food within normal portion. This side effect lead to the low food intake as evidenced by Mr. T's diet history. Nausea, vomiting, and diarrhea also can reduce food intake. Next, based on the assessment data obtained, Mr. T BMI is in normal class, which is 22.3 kg per meter square according to WHO classification. However, based on the data, Mr. T calories intake was 979.8 kcal, which is lower than his energy requirement daily of 2280 kcal. Based on full blood count data, hemoglobin and red blood cell level was lower from normal range. This data indicate that Mr. T has iron deficiency anemia and undernutrition. Other than that, based on liver function test data, albumin was lower than normal range. Low level of albumin indicates that there is infection, ascites, cirrhosis, and protein malnutrition.
Hi, I'm Hakim. Now I will continue the discussion. Regarding Mr. T's energy requirement, EER has been calculated and should be 2280 kilocalories per day. However, due to the current intake being too small and far from the requirement, we decided only to increase 50% of the current energy intake for this intervention session. It is important to avoid any stomach discomfort due to sudden increase of the energy intake and to stimulate his appetite slowly. 50% of the current energy intake will be 1500 kcal per day. For an adult, the daily iron requirement is 40 mg per day for 10% viable. However, Mr. T's iron intake is only 5.8 mg per day. Due to small food intake, the total protein intake is also low, which is only 31.6 grams per day. Nevertheless, the protein catabolism will increase due to his disease, which are hepatitis C and peritonitis. So, we increase his protein intake in menu suggestions according to the EPR, which is 1.2 to 1.5 gram per kg. After calculating, we decide to give 20% of the protein to Mr. T, which is 75.2 gram per day. High protein intake is also important to support the immune system and increase more white blood cell production to against the current infection. In addition, we must restrict the fluid and sodium intake due to fluid retention in his body and can lead to abdominal ascites. The weight that he should be restricted to is 1000 ml to 1500 ml per day only. Meanwhile, sodium is restricted to less than 2 grams per day. As intervention, we increase the iron intake in his menu by varying the iron sources including animal and plant sources. Non-heme iron comprise numerous organic types such as ferrous citrate, ferrous gluconate, ferrous fumarate, and ferritin, and inorganic forms such as ferrous sulfate, carbonate, and chloride, as well as ferric, with different forms of absorption and efficiency in each type of iron, primarily found in legumes, cereals, and other vegetables. As for animal sources, we include more fish than meat due to its high iron and low in fat. Besides, we request that Mr. T is more likely to eat fish than meat since his dietary history only includes the fish. Monitoring and evaluation for Mr. T includes monitoring his weight changes weekly to make sure that the patient is not gaining weight due to ascites. Monitoring the patient's dietary and fluid compliance to ensure that the patient reaches 50% of his daily energy requirement and fluid is reaching the recommended intake to prevent water overload. Monitoring iron intake through evaluation of his blood history and biochemical data which are RBC and hemoglobin value. However, RBC and hemoglobin value will be assessed for 4 months. This is due to human red blood cells that have prescribed a lifespan of about 120 days before being cleared for circulation. For the conclusion, Assessing and evaluating the underlying causes of disease is crucial in developing medical nutrition therapy for the patients. In this case, Mrs. T is diagnosed with spontaneous bacterial peritonitis and referral effusion with UL chronic hepatitis C, which this disease affects the nutrition intake in his daily life. The intake of drug has reduced. The appetite thus reduce the energy intake per day. Due to his health complication, some medications were prescribed to control the symptoms. For the dietary management, the intervention focused on to improve the protein and energy intake, reduce fluid retention in the peritoneal, and to improve the anemia condition. Small and frequent meals, weight and sodium restrictions, and intake of foods with high content of protein and iron has been implemented in this dietary intervention. Types of food that can inhibit the absorption of the iron also have been considered for the menu planning. For this intervention, it may improve the nutritional status of the patient, thus reduce the complication of health condition from worsening. So that's all from us. Thank you.